This presentation is by Summer Gentry, Kyle Swafford, and Kayla McKinn.
Hey Mrs. Estep, this is Kaylee McKinn, and I'm going to be discussing the overview of quality safety measures in an organization. What are quality dashboards? Quality dashboards are a system used to track key performance indicators within an organization. It is meant to be designed easily to read and quick to understand, providing signals of where things are going really well and where there are problems that need to be addressed and solved. If there are goals and milestones that need to be met, this will also help with that as well. What is a quality indicator? A quality indicator is a standardized, evidence based measure of healthcare quality that can be used with readily available hospital and patient administrative data to measure and track clinical performance and outcomes. It's generally chosen because they generally correlate with greater patient safety. How are quality dashboards used for an organization? Regular monitoring of data is critical for efficient decision making in any organization. However, when there are loads of information and all the data is getting scattered, it can be very time consuming and overwhelming. A dashboard used for an organization is an ideal way to prioritize the most important indicators for a particular organization and encourage regular monitoring of the results. How are quality dashboards used for a unit level? Dashboards can be used at a unit level to monitor and guide interventions aimed at improving the quality and safety of patient care. How is data collected for quality dashboards? According to an article on pmc.gov, quality dashboards are once again intended to improve patient care. So there are many ways that we can collect data for these dashboards. According to the CDC, it is important to record data over 1,000 catheter days. On the next slide, we will have a better example to show you. But basically, from this particular article, they took the total number of days and multiplied that by the total number of cautis that they had on the unit. And they take it on the first of every single month, and that is how they get their information. Hey Mrs. Estep, this is Kaylee again, and I'm going.
This is Summer, and I'm going to be talking about the evidence-based interventions. The first article is Quality Improvement Research Project. The 2 units with the highest cauti numbers got chosen. The 4-unit nurses participated in an educational program that includes face-to-face instruction, knowledge assessment, and skill acquisition and competency. A pre and post design was used to assist nurses' knowledge of indwelling urinary catheters and cauti incidents for each unit. The results is a total number of 59 nurses completed the educational program over a 3-month period. The test revealed significant increases in the nurses' knowledge summary score and across all 3 knowledge subscale scores. The number of cauti incidences decreased significantly. The second article is about a 245-bed Bourbon Community Hospital with a 16-bed critical care unit that was chosen for the study. Average rates were 2.8 cautis per 1,000 catheter days. Article 3. Saving Lives and Reducing Harm, a cauti reduction program. Beginning in 2015, the Centers for Medicare and Medicaid Services altered the and reporting structures around the hospital acquired conditions. This particular hospital had a really high rate, so their numbers got looked into. Cautis costed hospitals $2.3 million and the healthcare system $9.5 million for the year 2015. The numbers were also significantly reduced when the hospital knew that they were getting watched. Catheter-associated urinary tract infections. Article 4 said it's important for nurses to keep up to date with the best practice, and it's a requirement set out on the Code of Midwifery Council in 2018. The guidance is based on systematic reviews of the available scientific literature and the consensus opinion of relevant experts in the field and is supported by the International Institute for Healthcare and Excellence. It indicates a dwelling catheter should only be used where no other suitable alternative exists and should be removed as soon as possible. Maintaining accurate clinical records help nurses to establish the clinical indication for catheterization, and it helps to guide the decision to remove the catheter. Article 5 states that cauti is a preventable infection, and while there is not one solution to tackling it, it is clear that a multi-phased QI approach to gather use in catheter care can reduce catheter usage and ensure the patient is receiving optimal care and research. This is Summer again, and I'm going to be talking about the role of the BSN nurse and leadership skills. Reduce unnecessary catheterizations, hand hygiene, early removal, unobstructed urine flow, educate healthcare providers on how important sterility is.
Hello, Mrs. Estep. This is Kyle Swafford, and I will be going over informatics and nursing. So, the nurse informatics must have reliable knowledge and technology in healthcare practices. For cauti management, this is an important skill to possess to record and implement practices to educate other healthcare providers. So, as a nurse informatic and nursing and how it correlates with everything in cauti management, it is good to know that you have to have the ability to record data properly, to track the data, and after you have the data recorded, to eventually incorporate it into a reliable argument or piece, and end up going to whether it's your nurse manager, other peers, and potentially plead your argument or any case as to change practices or anything along those lines. So for nursing informatics and education of cauti, this goes hand in hand. Communicating data collected and knowledge through a factual basis could provide a strong argument to implement new practices. So as I was saying, once you have the data collected and you think you have an idea of what you want to change, on top of the process of having your data recorded and everything else, that is whenever you bring your whole argument together and you say, well, I have 15 cauti cases from this last quarter just in ICU, and I've spoken with a nurse manager over in the ED, and they have roughly 10 cauti cases. So from there, I think we should end up changing the practice for cauti management. And pretty much that's one of the biggies on nursing informatics. You collect your data, and if you feel that a practice needs to change, that is whenever you back up your argument with the factual data. So for data mining relevancy, this is a strong incorporation due to higher amounts of data yield better reasoning and need for improvement. So as I was saying, if you go to this nurse manager or if you go to any administration, it's really important for you to say, I've got all this data from not only my unit or the following other units, and you end up telling them that this is my information. I've done my homework, I've done my background, and everything else, and you end up tackling it with very factual, objective data, and that'll only just strengthen your argument for whatever provisions or practices or interventions you're trying to change. And so lastly, for changes, I would continue to practice the aforementioned topics and practices to continue to prevent cauti. So as Summer had said, there's, you have quality research projects that they've done. You've got Bactrim and Cranberry, I believe, and it's just what we're doing now. It's important to continue. And I think that is all I can say on this slide. I'm going to progress to the next one. Hello, Mrs. Estep again. This is Kyle Swafford, and I'm going to be doing the summary portion of this PowerPoint for cauti. So the performance measures show on sample platform a total of about 15. The other study showed that out of 245 hospital beds with 16 critical beds, an average of 2.8 cauti per 1,000 catheter days were involved. This is as found by Gesmondo. And so this is really important to note that Per 1,000 catheter days, we had 2.8 cautis. So that's just super, super important to know. And so moving on to the next point, observing for a deficit is important to look for as it shows if hospital practices are effective or needing revision for further improvement. With something like cauti, it is I had completely, but I meant to like put it in italics completely, because while it can be preventable, it's obviously not completely preventable. The only surefire way to not have cauti is to not have a Foley or not have a catheter and just straight cath someone. But what I was going to mention with this point is when I was working or not working, but when I was doing my clinical rotation in the hospital, one of the physicians, my patient that I was dealing with had a stroke and a bunch of other complications, including neurogenic bladder. And the patient was alert and orientated to self and was unable to feed self and do a bunch of other ADLs. And obviously, with neurogenic bladder, he was unable to urinate frequently, and they ended up checking his INOs, and the guy had roughly about 1,000 intake, and with him attempting to urinate, he maybe had like 80 mLs every 2 hours. And they ended up straight cathing him and ended up pulling out about 800 milliliters. So, anyways, long story short, the physician ended up going to the family and said that he did not feel comfortable giving him a Foley because while that would fix the issue completely, they ended up giving him some medicine that was for BPH, and one of the side effects is obviously to lower your prostate and shrink the size. And what that did is it helped him urinate a little more frequently and let him alleviate some of that pressure that he was feeling. And I felt that it was super, super important on the physician's part and also the nurse that was attending for the patient that to end up pleading his cause and like what he was not necessarily going through, but also with having the neurogenic bladder, the physician felt that while it would have ended up saving everyone so much time and effort by getting him, just a Foley and, say, forget about it, we're just going to give him a Foley and that'll fix the problem. He felt like with medical interventions, this would have had like the best of both worlds. It would have fixed his bladder retention and urinary retention while also not really diverting the issue to potentially cauti and UTIs. So continuing to educate healthcare professionals as well as skill reviews, this is every certain amount of this time is vital. Having hospitals constantly audited on numbers would potentially push for better results. What I felt with this is that it's super, super important for all healthcare providers, regardless of your level, physician, nurse, CNA, LPNs, that any skill specifically with, in this context, catheter introduction, is to have, like, for every a year or so, just do credit reviews and end up assessing their skill levels. And for this one, it will be catheter insertion, like how will they do the sterile procedure, and for physicians also like continue to educate them based on catheter information or prolonged amounts of times and what the physician could do to avert this situation. Like I had experience with the physician and attending to the patient with a neurogenic bladder. Excuse me. So hospitals and other healthcare institutes should be more inclined to improve cauti rates outside of the ideation of lost money. So I guess from like a business standpoint, hospitals end up thinking, oh, we've got 4 cauti cases in the past quarter. We're just going to count this as our red. We're in the red. We have to eat the bill and everything else. But what if it was eventually brought to the business partners and everything else that instead of losing money, they could think of the patients as numbers, not necessarily lost income and everything else. And so this is our presentation on cauti, and I believe that's all I can say. I will be moving on to the next slide to briefly go over the citations. Hello, Miss C-Step, one last time. This is Kyle Swafford, and this is our citation list. Pretty short and sweet, just 3 of them. And I believe that would be all. Thank you.
To be analyzing the data for the quarters. I did not circle, but if you take a look, right here we have cauti for the unit specific for this particular hospital. For quarter number 1, the target was to have 0, and the actual number was we had 2. And if you go on to quarter number 2, the target was to have 0, and we had 3 UTIs associated with catheters. And then if we move on to quarter number 4, the target was once again 0, and the actual number that we had was 4. So it did increase. It did stay the same in quarter number 3 as it did in 2 with 3, but we did gradually increase overall, which is not good. That is not the goal that we want, especially when these can be prevented. And then if you go down to actual hospital-wide scores by number of patients, once again, quarter 1 we had 3, quarter 2 4, quarter 3 we had 5, quarter 4 we had 3. So there really is no correlation, but the point being is we are having way too many than we want. We do not need these when they are preventable. And that leads me to why we are measuring this indicator. As we discussed earlier, we are taking a large amount of data and easily tracking indicators to see how we are preventing cauti in the hospital and if we are meeting our goals. This should have nurses aware of the issue with cauti and doing every step necessary to help prevent it. Among UTIs, the most common type of hospital infection acquired in the hospital, approximately 75% are associated with a urinary catheter, which, as we know, is a tube inserted in the bladder through the urethra to drain urine. Between 15 to 25% of hospitalized patients and 90% of ICU patients receive urinary catheters during their hospital stay. The most important risk factor for developing a catheter-associated UTI, cauti, is prolonged use of urinary catheter. Therefore, catheters should only be used for appropriate indications and should be removed as soon as they are able to, and as soon as they're able to be taken out, as well as nurses always use an aseptic technique. The goal is to reduce cauti because of its leading to extended hospital stays, increased healthcare costs, and patient morbidity and mortality. This can lead to, for example, sepsis. This just causes more stress on the hospital. And to answer another question, the CMS does not provide reimbursement to hospitals for any catheter-associated UTIs because, as I stated earlier, this is something that we think can be prevented. Thank you.